So next is case discussion about acute pancreatitis. May I call upon the discussants. Dr. Hemant Naik, Associate Professor, AIIMS Bhubaneswar. Dr. Devashish Mishra, IPJMR Kolkata. Dr. Itish Patnaik, Associate Professor, AIIMS Rishikesh. Dr. Kavita Sambat Kumar, Senior Consultant from Chennai. And the presenter is Dr. Ajay Kumar, he is a consultant from Max Hospital, Delhi.
To help me to guide you through all this panel discussion. Start from a case capsule. A 45 years old male had a pain, severe pain, upper abdomen, typical of pancreatic pain for 1 day and associated with vomiting, mild distension, tachycardia, tachypnea, and abdomen showed mild tenderness, distension with sluggish bowel sounds. Patient was not alcoholic. 6 months back, patient had a pain in the right hypochondrium which was not evaluated in detail. Patient had been in past treated with pulmonary tuberculosis, non-diabetic, non-hypertensive, no history of any recent drug intakes or CAM. Patient came to emergency, the resident saw the patient, ordered plain X-ray which showed the transverse colon was dilated and there's no free air. And the biochemical investigations documented significant rise of amylase lipase, hypoxia, SO2 94 on 2 liter oxygen. In addition, patient had mild rise of transaminases and bilirubin. Ultrasound showed gallstones, CBD 7 millimeter. As usual, the radiologist said CBD can't be evaluated because of dilated bowel, which is a usual thing in this setting. Pancreas showed some peripancreatic collections. With that, Dr. Hemant, patient comes to you as a first. What is your diagnosis?
Sir, possibly we are dealing with acute pancreatitis.
Louder.
Acute pancreatitis, possibly etiology biliary, moderately severe, because the organ failure is not there. It may be transient organ failure, because it is fulfilling all the 3 criteria of modified, revised Atlanta criteria.
So the 2 of the 3 criteria, clinical, biochemical, morphological, have to be met to make that sick. And this particular patient, there is no debate that it is an acute pancreatitis. And to comment on the etiology, because we had a gallstones, we had a rise of transaminases, so we kept the possibility of an acute biliary pancreatitis. And that we went on to talk about later, but then just to briefly mention here that in today's setting, when we look at that, please, we do all talk about alcohol, gallstones and so on, but please do not forget to look at triglycerides and hypercalcemia. It's our protocol to include the assessment of triglycerides right on the 0 hour, so that because later on they can come down to normal and you may not come down and they may not be that significantly high. It is just to bring to your notice for the postgraduates that you should be cautious about that. Dr. Devashish, now when the patient is there in the emergency, you have this diagnosis. Now how do you triage the patient? Basically, the patient goes to higher center, or if it is in the higher center, goes to the ICU, goes to regular ward, or you send home with medications?
So our patient has SIRS, as he has tachycardia and tachypnea. So I will be cautious and I will admit him and will be in a monitored setup. So preferably in ICU or monitored setup, because he has SIRS, which is a predictor that he might land up in severe pancreatitis later. And obviously in this patient we will not send him home, but a easy scoring system such as HAP score can be applied for other patient if we think that we have constraints of bed, as many of us work in a public hospital and we face that constraints of bed. So if the patient has non-tender abdomen with low hematocrit is not very high, not more than 44, and creatinine is below 2. All of these criteria are met. Harmless acute pancreatitis course is there. So in only those subset of patients we may send them home. Otherwise, we will not send patient of acute pancreatitis to home.
Right. So what is, see, there are multiple diagnostic criteria to predict that this particular patient may go into the severe pancreatitis, which takes about 48 to 72 hours to show its true effect. But right at the onset, the criteria may not be many. People are talking about IL-6, but so if you to sum up that if you have any features to suggest organ failure, then we treat as moderate or severe acute pancreatitis and let the things unfold, but we cannot delay the interventions waiting for 72 hours for the things to show in a full way. And of course, we are all aware of the revised Atlanta classification. This audience doesn't need to be focused on that. Basically, to remember for the postgraduate that the moderate degree is the transient organ failure is a part of the moderate pancreatitis, and of course there is a difference in the local complications and all that. So once we have seen this patient, we take a decision on that, and this particular patient was diagnosed to have acute pancreatitis, possibly moderate to severe category on the basis of clinical picture. And as rightly said by Dr. Hemant, that we shifted the patient to the intensive care. And question is, if you are in a small center and if you have a persistent surge or organ failure, all these patients should go to a higher center because you can have a stormy course over the next days, and unless you preempt it, one can have challenges. Dr. Itish, now the immediate thing when the patient comes to us is the pain. Now patient needs analgesia. Now what is your policy, what analgesia, and what is the evidence on that?
Okay, so this patient is having severe pain. So regarding pain, we had discussion in the morning also. So most of the guidelines, they do not address this issue. Unless the recent guidelines, 2025 IAP published, they said that either NSAID and opioids both can be used. Though in patient with a severe pain, opioids tend to do better. So in our practice, like it depends on institute where you practice. Our practice mostly we use NSAID or low potent opioids like tramadol and rescue analgesic, especially in the form of opioids like fentanyl. But again, it depends to center. We do not use PCA, for which you require a dedicated pump for that. And regarding the literature that NSAID versus opioids, I think 2 meta-analyses published in 2022 which showed that both are equally efficacious, though rescue analgesic requirement will be higher in NSAID groups, but there is no difference in adverse event rate. 2 trials from India, one from AIIMS Delhi, one multi-center trial from PGI Chandigarh. So AIIMS Delhi again showed that opioids are better than NSAID in terms of like they have higher pain-free interval rate and less rescue analgesic requirement. So I think at present we know because pain is severe, so we consider opioid, though NSAID is an option where there is no contraindication and both are equally safe.
Do you have any experience with the epidural anesthesia?
Very few experience epidural. So what we know that because again it is require multi-department coordinations. But epidural, what we know that thoracic epidural is preferred. It is safe apart from transient hypotension and it is effective also.
We had a trial at thesis protocol at our center. It's okay, there are 2 theories behind it, that it's effective and also probably it improves the pancreatic secretion, so it may improve, may lessen the necrosis. But we didn't find any specific significant difference. But the biggest challenge is for this you require a specialist to offer that, and it's not easy to maintain that. And that's a practical challenge that we found in that.
The possible indication where patient is having severe pain, not responding to opioids, and especially contraindication to opioids where he can use it.
So the protocol that we follow is this: NSAIDs are preferred over opioids. Paracetamol is given round the clock. Tramadol SOS to tramadol 8 hourly, And if the patient is not responding, then we shift on to fentanyl infusion and the patient-controlled anesthesia. Though Pramod and PJ both had shown diclofenac, yes, it is a wonderful drug as far as the analgesia is concerned, but one is always cautious, especially in a patient who is in hypertension or in a elderly. So we reserved it for a select group, and as far as the pentazocine is concerned, which Pramod's group had shown is useful. Some of the other, our hospitals are not even allowing us to know pentazocine. Anesthetists are strongly opposed to that, and they don't allow it to be available. So that's the protocol that we use in our patients. Dr. Vinod, now the next decision is quite often the patients, the emergency staff rushes that get a CT scan done. Now, what is your opinion on that? When it should be, I ask all the questions are there. Why do you need CT, when and how, and can CT worsen it, or will you substitute with MRI?
So, CT was not routinely asked for diagnosis. We do clinical diagnosis, and once the amylase lipase are elevated with clinical symptoms, we don't ask for a routine CT. But of course, like CT helps in defining the extent of necrosis and also the severity of pancreatic inflammation. So if at all CT has to be
If you permit me to add here that we will ask for a CT only in a situation when we are not fully certain about the basic diagnosis, because we don't want to miss any perforated viscous or any ischemic bowel. Ischemic bowel is a big thing that you can miss.
And if the patient doesn't improve after 3 days, even with IV hydration, we ask for a CT. Routine CT is not, we ask for it. Regarding the severity, yes, we have this Balthasar and CTSI scoring. Now we have this modified CTSI scoring, which incorporates both pancreatic inflammation and also pancreatic necrosis, along with these extra pancreatic complications. Out of 10, if it is more than 8, we call it as acute severe pancreatitis. So it helps us to, prognosticate the patient and how to, whether to patient we have to admit in like ICU or we can deal with what. That's prognostic indication. CT is helpful, sir.
And what is the right protocol to do? Do you require the same old protocol like 100 to 150 mil of contrast at 3 mil per second with a modified scoring, or you don't need? Because some of radiologists feel that you don't require the same amount now. Do you agree with that? Anybody? Yes, Doctor, you want to say something? No, okay. Okay.
So dynamic contrast CT is indicated 100 to 150 ml. It's needed 3 ml.
It's a practical question because it's a very high amount of contrast which is recommended and which can cause kidney injury. Anybody's comment on that? Because some of the radiologists feel that with the modified criteria you don't require that high amount. Okay.
Nowadays we started using less amount of contrast using the pancreatic protocol. So the less amount of contrast will help us within 3 seconds of infusing the contrast to look at the pancreas more. Okay. But if you suspect more of collections in the blind CT, then we increase the dose and just look into it to find out. Otherwise, nowadays we started using only less amount of it.
So Dr. Kavita, now come to the most important part. We know that there are very little specific interventions which we can do to change the natural course of the disease. All those things have been discussed in great detail and in the morning. And fluid therapy has also been discussed. Here we only want the carry-home messages for the fluid therapy in acute pancreatitis. The questions are many which I put here, and if you could take up one by one, that why do you need that?
The fluid therapy, we always know, is the mainstay of treatment for acute pancreatitis. The main goal of treatment of acute pancreatitis and fluid therapy is to prevent the hypovolemia and increase the perfusion in the pancreatic tissue so that we increase the cardiac volume by giving more amount of fluids. Nowadays, after the waterfall criteria which is published on NEGM, we have started using less amount of fluid management.
Before you go into the waterfall trial, can you just define, because we keep on talking low fluid, moderate, aggressive. What exactly do we mean by the moderate and aggressive?
Sir, it depends on the patient, how they present from the acute pancreatitis to the day of the presentation and hours of presentation. First, assess the shock status, assess the fluid dehydration status before start infusing the fluids. Initially, we thought the aggressive fluid will help the patient. Nowadays, the aggressive fluids, when we give lot of fluids, like Japanese criteria where they use more than 600 ml within an hour, we feel most of the time when the patient is not roundabout in the ER or ICU, the patient may go for a fluid overload and they may perfume over acute pulmonary edema and death is happening. So when we come to the criteria of low of fluid bolus, about infusing 10 to 15 ml per hour per kg in initial few hours, within first few hours, reassess the patient very frequently to assess the patient, then followed by 1.5 ml per minute per hour per kg, and also monitor the urine output. In the initial hours, we may not have a good urine output, but we should monitor the urine output of at least 0.5 ml
so
per
just
minute.
to reiterate what you were saying, that the key message is that now after the waterfall trial, the one thing is pretty clear, that the amount of fluid, it has
Yes.
to be moderate, not aggressive.
Yeah, another now also, sir, we also know that mild pancreatitis case, there are most of the time the fluid overload may be around 3.5 liters, whereas in the acute severe pancreatitis, the fluid overload may go up to 6 liters. In such a case, a small amount of diuresis may help the patient sometimes. We should not be not aggressive to give a slow dose of diuretics. Even a 20 milligram of Lasix would really help the patient to increase the urine output as well as the perfusion. So this can be used nowadays, which may help the patient to give a good sign.
So the current guidelines, according with the evidence now, is a bolus of 10 ml per kg with a 1.5 ml per kg per hour, and this is called the moderate infusion. And question is about the watch fluid. That is also settled because we'll run shorter. Can be quick in that.
We
Yes.
usually use within first 24 hours is the maximum fluid we are going to resuscitate. Whether we are going to use whether crystalloids or colloids matters much. So nowadays we started using the ringer lactate, where the plasma chloride levels is around 104 to 110, whereas the chloride level in the RL will be around 109. So it will be an ideal fluid to manage the patient in initial 48 hours. At the end of first 24 hours, reassess the patient. If the patient is started improving, then you can reduce the fluids. If the patient is not improving within 48 hours, then reassess the patient again. Once if you started introducing the oral fluids, wait for 8 hours. If the patient is getting more improved, then come down in your fluids, even if you may stop it.
So the moderate fluid, most important is first 24 hours. The problem with most of the tertiary care center is patients reach there later than that. So it's very important in the periphery to train the doctors treating them at the primary, secondary care, that this fluid part is important in the first 48 hours, and it should be done even before it reaches. I mean, we hardly ever get a patient on the first day in our...
most of the time patient reaches little bit late because he presented with abdominal pain with the local doctors, where they treat it as an ordinary abdominal pain. Only when he present with lot of vomiting and when he come with the shock, only he reaches. So by that time we would have completed 24 to 36 hours. We should be very careful in selecting the fluids and giving to them.
And this lesson is also very well clear that the crystalloids are the preferred, and not going to too much of details of that. And question is, how do you monitor?
So as per the
what is your regular guidelines for the residents, that how should they be monitoring?
Sir, as per the recent criteria, they say the mean arterial blood pressure should be maintained at least more than 65. At least we try to maintain around 70 millimeter pressures, so that it helps in adequate perfusion of the body, so that we don't infuse a lot of fluids. At the same time, we should monitor the urine output at least 0.5 ml per kg. So this should be very careful in the patients, and also they maintain the hematocrit at least less than 43 to be maintained, so that it should not be an over concentration to the patient. So patient may again aggressive of the AKA may be aggravated.
So it's very important for the critical care people to have an ultrasound monitoring. That is, and all critical care staff should be treated. Our residents are posted in a gastro ICU, and they are the ones who are monitoring it, because over infusion is more risky than even under perfusion. That's the lesson that we have to understand. And Dr. Hemant, we had an excellent talk by Dr. Murthy on the antibiotics. I know lots have been covered, but I'd like to briefly touch you on the, want you to touch on that, what is the rationale? Rationale was well discussed. What is the evidence for that, and what are the current guidelines?
Sir, in case of first week, in first week of acute pancreatitis, there is no rule of prophylactic antibiotic. Rather, if you use antibiotic, it increases the risk of bacterial resistance as well as fungal infection. So various guidelines recommends no prophylactic antibiotic for acute pancreatitis during first week. However, antibiotic is
What
recommended
exceptions you will make to the use of these antibiotics in the first?
only in case of infected pancreatic necrosis, if there is air inside the pancreatic necrosis, and for extra pancreatic infection, for example, simultaneously urinary
Extra
tract
pancreatic infection, if the patient is on an intubated, on catheters, or whatever the ICU policy, but then your choice of antibiotic changes according to your ICU protocols. And the second thing, exception, will you like to make a biliary pancreatitis and a cholangitis?
Cholangitis.
And then you select your antibiotic accordingly. So current evidence is that antibiotics are not useful in preventing infection of pancreatic necrosis, reducing surgical intervention and mortality in patients with severe acute pancreatitis, and across the world, different societies' guidelines do not recommend as a prophylactic antibiotics. And this again point was discussed in the morning, in the just afternoon today, that if you give prolonged long antibiotics, there is an increased risk of gram-positive infection and increased fungal sepsis, which adds to the problem. People have used markers, and Dr. Kumar and talked about NLR and your procalcitonin. What is your take on that?
Sir, elevated procalcitonin.
What is the current evidence and the agreement on that?
Sir, if procalcitonin level is elevated, it is considered as a sepsis marker. Again, it is not 100% specific.
There is a few papers on that. They probably protocol as a guide, but probably yes, but it's not still definite. And we need more markers to pick up early. And of course, the role of intervention, needle aspiration was discussed and not encouraged, not recommended, not practiced. So no prophylactic antibiotics. Any pre-intervention procedure, that yes, you will give it, but Procal probably you use. Dr. Devasis, after the fluids, this is the most important issue of the nutrition in acute pancreatitis. The questions are there: whom to give, when to start, how to give, and what to give. And can you take up these things?
So whom to give? All the patients require nutrition because they are in a highly catabolic state. Now, when to give, it is as early as possible, maybe 24 to 48 hours. For the mild pancreatitis, and if the patient does not have significant pain, abdomen, nausea, or vomiting are absent, we can start with diet, oral diet itself, low-fat oral diet, we can start. But on the other hand, if the patient has moderate to severe pancreatitis, where the calorie intake might not be optimal for the particular patient, we can think of the enteral feeding, either nasogastric or nasojejunal, and with the liquid diet we can start. And only if the patient is not tolerating the enteral feeding either by the nasogastric or even with the nasojejunal, we can think of starting parenteral nutrition, but that is only a very small
though there are
subset.
3 randomized controlled trials showing nasogastric as effective as let me take a show of hands in the audience. How many people actually use nasogastric in the first, say, 3 to 5 days? Okay, how many of them you will see that they will actually tolerate? Because the number of hands gone up is not very high. It's very, so the point I'm trying to, the evidence is there. There's no debate on that. And problem is acceptability both by the patient as well as the doctor. I think there's a hesitant. So I think we need to look into that. So that's the reason I said it is still not fully accepted in the regular day-to-day practice. And how long you would like to give the nutrition? I mean, timing of nutrition. What is how early do you like to start it, and how is important?
As early as possible, maybe 24 to 48 hours. We should start within 24 to 48 hours.
So, in severe acute pancreatitis, enteral nutrition within 48 hours compared to late enteral nutrition shows a significant reduction in mortality, organ failure, surgery, systemic infections, and localized septic complications. So we have enough evidence for that. So the current recommendation is that jejunal feeding should be started within 48 hours. Here you can change it to the nasogastric as well. Optimal feeding formula is unknown. Ensure the jejunal placement of the tube. Monitor for hypertriglyceridemia, hyperglycemia. TPNE patients who do not tolerate enteral feeding, otherwise it is discouraged. And there's no role of any specialized nutrition. Don't increase the cost of the patient. So if you look at this, if in the last 20, 30 years, if there is a remarkable change in management of acute pancreatitis and it's gone full topsy-turvy, is the nutrition. Right? We were taught it's fasting, give rest to the pancreas. Then we were told TPN is better. Then we say early jejunal feeding, and now we say early jejunal feeding is superior, and now we have come to the early gastric feeding is as good as jejunal feeding. That's something remarkable, the changes have taken place. Itish, a lot of talk about organ failure, the different things in the morning, I mean, elegant lectures on that what can be done. Some people talk about microbiomes and obesity, fat. Some talk about renal replacement therapy. Do you think, I mean, we all understand that the organ failure is the key element which determines the prognosis or the outcome. Do you think today is anything that you will practice in a select population or anything in the pipeline?
Sir, organ failure by virtue, here we mean that primary organ failure which occurs in the first week or second week and occurs due to cytokine storm. The organ failure which sets in later is due to sepsis, and obviously the treatment is straightforward, that you treat with antibiotic and drainage. Regarding organ failure due to cytokines, I think once sets in, then we don't have much to offer apart from good supportive therapy. Regarding pipeline, yes, there are trials and ongoing, and many trials they didn't found also benefit. Like there are trials ongoing like injection of lipase inhibitor, US guided injection of lipase inhibitor, use of heparin, and also there is a trial ongoing for steroid in the pancreas. So till now we...
That's I think came from, again, from Pramod's group, from a role of steroid. How many of us have ever used renal replacement therapy in a severe acute pancreatitis with multi-organ failure? How many of us use it? There are a few hands there. So people, obviously we know that the evidence is still not strong, but then in desperate situation, I personally will tend to go in a multi-organ failure, third day, fourth day, patient not responding, when we know that, I think I personally will take a chance. Pramod, what is your comment on that? Yes, you will take a chance because it's a desperate situation, right? We don't know as yet how useful it will be. Okay, Dr. Vinod, this particular patient, we confirmed that it's acute biliary pancreatitis. It is moderate and was recovering. My question is, what is the role of emergency ERCP in acute biliary pancreatitis?
It's not, usually indicated except in two scenarios. One is in cholangitis. The patient is in cholangitis, we do subject the patient for an emergency ERCP, or if it's a worsening cholestasis, if the enzymes got increasing day by day, probably the stone might be there and we have to do an emergency ERCP. Otherwise, we can wait. The idea is like the stone from the bile duct causing obstruction of the pancreatic duct will fall on its own to the duodenum. So we can wait. There is no need for an emergency ERCP in all cases of acute biliary pancreatitis.
I think the most important thing is that don't rush for it unless you have some gross evidence of cholangitis. And mind it that even in a patients of acute severe pancreatitis, quite often it's difficult to differentiate between SIRS and cholangitis. So prerequisite to do that is to do some bile duct imaging. And here we have two options. Either you do an MRCP or you do an endoscopic ultrasound. Because once you take, so quite often these patients, if they are sick enough and they are not cooperative to undergo MRCP, so you might as well take them for EUS and go for ERCP only when you document, because it has been shown that in patients of acute severe pancreatitis, one, the ERCP is technically challenging because of severe edema in the duodenum, and two, if you fail while trying it, your complication rates are much higher. So that's a very important part that we need to remember, and we need to take the patient, take a decision according to that. With that, I come to the last question, and please must give a clap to all the the panelists here. They're sticking to the time and finishing in time, the whole thing. And the last question is, Dr. Kavita, in this particular patient, what will be your timing of cholecystectomy? Because 90% of surgeons that we come across are reluctant to do the cholecystectomy in acute. But what is the current guidelines for that?
So, according to this patient, it is the patient of moderate to severe pancreatitis. So, usually we want to wait for 6 weeks to do the cholecystectomy. If it is going to be the mild pancreatitis, in such a case, if the patient is so good, then we can think about the first week of cholecystectomy. Otherwise, ideally to wait for 6 weeks to the pancreatic inflammation to settle in. So it helps the surgeon for the laparoscopic removal. Otherwise, they may also find it difficult and they give us a lot of complications.
So if it's a severe pancreatitis, we tend to postpone the surgery, but then please make sure that if you're doing ERCP to clear the CBD, you put in a stent, and then that will be safer to prevent, because 50% patients can come back with a second episode of pancreatitis within 4 weeks, and that's what data shows. So friends, I conclude by summing up, and if there's any last minute audience question, we can, panelists can answer that early prediction of severe acute pancreatitis is useful in triaging and prognostication. Fluid resuscitation is the most important intervention in the first 48 hours. Ringer lactate is the current choice of fluid, and no prophylactic antibiotics are recommended except in situations which we discussed before. Early enteral nutritional support in severe acute pancreatitis is positively helpful in reducing infections, and emergency ERCP is to be done only in cholangitis, and cholecystectomy in the same admission for mild acute biliary pancreatitis. Thank you very much. Any quick 1 or 2 questions, we can really handle that. Well, if none, then thank you very much. And
Thank you.